This is Medicosis Perfectionalis, and we're talking about CNS pharmacology. This is antipsychotics or anti-schizophrenia medications, part 1. Let's get into it. In schizophrenia, I have too much dopamine, specifically in the mesocortical and mesolimbic pathways, leading to psychosis, euphoria, hallucinations, delusions, etc. Let's review the dopamine pathways. Dopamine at the nigrostriatal pathway, movement. Too much dopamine, too much movement. Too little dopamine, no movement. And that's why when we give antipsychotic medications, they are trying to decrease dopamine to cure the psychosis. While decreasing the dopamine, they will also decrease it in the nigrostriatal pathway, leading to extrapyramidal side effects. Basically, I have movement disorders. So what is the cause of extrapyramidal symptoms? And the answer is antagonism of dopamine receptors. Dopamine at the mesocortical and mesolimbic pathways has the function of mood and reward. Too much dopamine? Oh, I'm on cloud 9. Everything is hunky-dory, but too much. Psychosis, euphoria, hallucinations, too much mood. Heightened sensations, heightened mood, hallucinations, delirium, etc. But too little dopamine, I get anhedonia. What's the purpose of life anyway? The addiction cycle is basically too much dopamine at the mesocortical or mesolimbic pathways. Dopamine at the tuberoinfundibular is antiprolactin. Let's review. So, you have a patient with psychosis or schizophrenia. What's his problem? Oh, his problem? Too much dopamine in his brain. So, I'll give dopamine antagonists, also known as antipsychotics, because we're trying to treat psychosis. Okay, I have good news, I have bad news. Good news. This will decrease dopamine or antagonize dopamine, leading to some therapeutic effect, less psychosis, which is awesome. But there are no solutions in life. There are only trade-offs. Dopamine antagonists can lead to extrapyramidal symptoms, Parkinson-like symptoms. Why? Too little dopamine in the system. Also, they can cause hyperprolactinemia. Because dopamine, may he rest in peace, was antiprolactin. But no dopamine, prolactin will go wild. Back to the basics. Schizophrenia, too much dopamine, specifically at the mesocortical limbic system. What is schizophrenia or psychosis? Disruptive thought process and emotional responsiveness. Look at this. I have positive symptoms and negative symptoms. Positive symptoms, I am like not a normal person, a normal person plus these symptoms. Okay, so I'm kind of normal plus delusions, paranoia, etc. Negative symptoms, get a normal person, subtract some stuff. A normal person should interact with you, laugh, cry, etc. No, flat affect, that's a negative symptom. A normal person should interact socially with you. Negative, social withdrawal. A normal person should be able to speak coherently to you. Poverty of speech. So what are the positive symptoms? Bizarre delusions, not just delusions, bizarre delusion. I'm the Messiah. The aliens are coming from outer space to abduct me so that I can carry out their agenda. Paranoia. I trust nobody. My mom is gonna poison me. Hallucination, especially auditory hallucinations. I listen to people talking to me. Bizarre behavior and thought disorders. The negative symptoms are flat affect, social withdrawal, and poverty of speech. Dopamine hypothesis of schizophrenia. They say that schizophrenia is associated with increased dopamine at the limbic system or increased number of dopamine receptor. Here's another theory. They say that there is increased number of dopamine receptors due to the diminished dopamine. In other words, it's a negative feedback. Who knows? Some medications can increase your dopamine at the limbic system. These medications can lead to drug-induced psychosis or drug-induced schizophrenia. What are these medications? Cocaine, amphetamines, bromocriptine, and L-Dopa. Tell me about the typical antipsychotics. What are we trying to achieve? To treat the psychosis. How do you do it? What's the problem in psychosis? Too much dopamine. Okay, I'll try to decrease dopamine or decrease dopamine effect. How do you do it? Block the dopamine receptors. D2 and D1, but specifically D2. This is huge. I have good news, I have bad news. When you block the dopamine receptor, this will improve positive symptoms. So less delusion, less paranoia, less hallucinations, etc. But they can worsen the negative symptoms, leading to dysphoria, more flat affect, more social withdrawal, etc. When you block dopaminergic receptors in the brain, this will lead to extrapyramidal symptoms because we decrease the dopamine effect in the nigrostriatal pathway. Also, it can lead to hyperprolactinemia due to decreased dopamine effect in the tuberoinfundibular pathway. What are these extrapyramidal symptoms? Remember, in neurology you had the pyramidal tract and the extrapyramidal tract. Both are motor. These symptoms are usually due to the extrapyramidal tract. What are they? Dystonia, akathisia, Parkinsonism, tardive dyskinesia. So I took my antipsychotic. It's the typical one, such as haloperidol. In the beginning, I can get dystonia. Later, akathisia. Even if I wait more, Parkinson-like symptoms. And later on, last thing, tardive dyskinesia. What's the cause? Blocking the D2 dopamine receptor in the brain. What is the treatment? You can lower the dose. You can switch to an atypical antipsychotic, which we'll discuss in the next video, or you can treat it symptomatically. You have dystonia, give benztropine. You have akathisia, benztropine. Parkinson-like symptoms, benztropine. Propranolol can also help. Next, the serotonin hypothesis of schizophrenia. Some medications can boost or stimulate serotonin 2A receptor. Perfect. This will increase dopamine. Oh, so when I stimulate the serotonin receptor, this can increase release of dopamine? Yes, indeed. These medications will lead to drug-induced psychosis or drug-induced schizophrenia. So if I have serotonin and serotonin binds to 5-HT2A, what's going to happen? Believe it or not, dopamine will decrease. So what's the difference? It really depends on who was stimulating the receptor. If it was the LSD, it will increase dopamine and I will get crazy. But if it was the serotonin, it will decrease dopamine. What if there was serotonin receptor antagonism? It will be the opposite, increase dopamine, and this is what we fear, because too much dopamine will make the patient even more crazy. And it's not the patient's fault. Too much dopamine at the nigrostriatal will lead to lots of movement, and this will decrease the extrapyramidal symptoms. So one of the ways to theoretically decrease extrapyramidal symptoms is by antagonizing serotonin 2A receptor. Increased dopamine at the tuberoinfundibular will increase dopamine, decreasing the risk of hyperprolactinemia, which is awesome. Blocking that serotonin will increase dopamine, leading to increased dopamine at the mesocortical, leading to less risk of dystrophic side effects of the blockade of the D2 receptor and decreased negative symptoms, which is awesome. This 5-HT2A receptor is abundant and more numerous than the D receptor in every location of the brain except mesolimbic. So when I block serotonin at the mesolimbic, this will increase dopamine at the mesolimbic, but not too much because serotonin 2A receptor is not very abundant here. This increased dopamine is not enough to overcome the therapeutic effect of the D2 antagonism of antipsychotics. So here is a theory. How do we get the benefits of the antipsychotics without all of the side effects of the antipsychotics? Combine them with serotonin antagonists. So typical antipsychotics, I had good news, I had bad news. For the typical ones, I improve the positive symptoms. Awesome, but I worsen the negative symptom. Not awesome. Atypical antipsychotics, however, they are weak dopamine 2 antagonists. They will improve positive symptoms and they will worsen negative symptoms, but this is weak. What are the side effects that might happen when you block D2 receptor? Extrapyramidal symptoms and hyperprolactinemia. Cool. But the atypical antipsychotics are strong antagonists of the serotonin 2A. Wonderful, because this will increase dopamine. This will decrease my risk of having extrapyramidal symptoms, decrease the negative symptoms, and decrease the risk of hyperprolactinemia. That's why atypical antipsychotics are better and have fewer side effects than the typical old-fashioned antipsychotics. That's why the atypicals are known as the second generation or the new generation of antipsychotics. Next, the glutamate hypothesis of schizophrenia. Here is glutamate. When glutamate binds to the glutamate receptor, in this case it's the NMDA glutamate receptor, on a GABA neuron, and as you know, GABA neurons are inhibitory, this will lead to GABA release, and GABA is inhibitory, leading to decreased psychosis. Awesome! So glutamate is our friend. Wonderful. But PCPs and ketamine is not your friend. Why not? Because PCP or ketamine will inhibit the glutamate receptor, the NAMDA glutamate receptor. This will lead to the GABA is not going to work. It's not going to release GABA. No inhibition. No inhibition. What do I get? Excitation, psychosis, and schizophrenia. And now you know why people who receive PCP or ketamine are kind of crazy. Let's talk about the typical antipsychotics mechanism. They block the D2 dopamine receptor at the mesolimbic. They will improve positive symptoms of schizophrenia, less delusions, less hallucinations, etc. What are these typical antipsychotic drugs? You have chlorpromazine, this is the prototype, the quintessential typical antipsychotic. You have haloperidol, pimozidine, thioridazine, fluphenazine, and others. Clinical uses: schizophrenia. Side effects: when you block D2, you worsen negative symptoms and you can get dysphoria. What's the purpose of life anyway? Dysphoria and anhedonia. This can decrease compliance of the drug. The patient will say, oh, this drug is making me feel horrible, I will not take it anymore. When I block D2 at the nigrostriatal, I can get extrapyramidal symptoms. This can decrease the patient compliance with the medication. Blocking the D2 at the tibial-infundibular will increase prolactin to hyperprolactinemia, will lead to galactorrhea. Hyperprolactinemia will also suppress GnRH, leading to decreased FSH and LH. In females, this will lead to amenorrhea. In males, impotence and gynecomastia. Impotence is the same as erectile dysfunction. These drugs also block others. They can block muscarinic receptors, alpha-1 receptors, and H1 receptor. When I block H1, I get sedation and weight gain. Case in point, diphenhydramine. When I block alpha-1 receptor, I get the side effects similar to prazosin. Case in point, orthostatic hypotension. When I block the muscarinic, I'm atropine-like. You can use this song or this 3C's song. Red as beet, blind as bat, hot as hair, dry as bone, full as a flask, mad as a hatter, and the heart is pumping alone with tachycardia. Or you can call it coma, convulsion, cardiotoxicity. In other words, yes, typical antipsychotics are very strong, but they have gazillion side effects. That's why we prefer the atypicals. These are the atropine side effects that we have discussed before. Red as beet, blind as bat, hot as hair, dry as bone, full as a flask, mad as a hatter. What do you mean by red as beet? Decreased sweating. Blind as bat, decreased accommodation. Hot as hair because decreased sweating. Dry as bone because there is no sweating. Full as a flask because there is urine retention and stool retention. Mad as a hatter because there is excitation and hallucination. The heart goes on alone. This is tachycardia. Or you can call it coma, convulsion, cardiotoxicity. Don't forget that atropine is contraindicated in acute closed-angle glaucoma and benign prostatic hyperplasia. Remember, prazosin, terazosin, doxazosin block the alpha-1 receptor. When you block the alpha-1 receptor, what kind of side effects would you get? Orthostatic hypotension and maybe impaired ejaculation. Because in order for me to ejaculate, the bladder sphincter has to constrict to prevent the retrograde flow of the seminal fluid into the bladder. If alpha-1 is not working, I did not constrict the neck of the bladder well, the semen will go backwards instead of forwards. Now, the side effects of typical antipsychotics include extrapyramidal symptoms. What are they? It depends on the time frame. Doctor, I took your haloperidol. 1 to 5 days later, I developed acute dystonia. And then, doctor, I took it. And then 1 week later, drug-induced Parkinsonisms. Weeks or months, akathisia. Even more weeks or more months, neuroleptic malignant syndrome. Months to years, the horrible tardive dyskinesia and perioral tremors. What is acute dystonia? Muscle spasm. I have tongue spasm, face spasm, neck spasm, back spasm. How do you treat it? Antimuscarinic such as benztropine or antihistaminic diphenhydramine. Don't forget that diphenhydramine also blocks muscarinic receptors. Next, drug-induced Parkinsonism. What do you mean? The famous triad: resting tremor, cogwheel rigidity, and bradykinesia. How do I treat it? Same way you treated Parkinson's, benztropine or trihexyphenidyl. Then akathisia. What is this? Restlessness. I cannot stand still. I cannot sit still. I have to keep moving my leg. It's so bad. How do I treat it? Propranolol can calm you down. Antimuscarinics such as benztropine or benzodiazepines. Neuroleptic malignant syndrome is a freaking emergency. You have high fever. You have catatonia, which means you are stiff and paralyzed and frozen in place. So you hold your hands up like this, or you keep looking upwards like this, and you're frozen for hours. This can kill you. How do I treat it? Start with benzodiazepine and dantrolene. If it's not improving, you can add bromocriptine or amantadine. Months to years, you get perioral tremors known as rabbit syndrome or tardive dyskinesia that could be freaking irreversible. What is tardive dyskinesia? Oral and facial dyskinesia. You cannot move your mouth or your face. Chorea and acidosis. Why is this? Due to D2 receptors upregulation and sensitization. The receptors got sick and tired of being sick and tired. You can give antimuscarinics for the rabbit syndrome, but there is no treatment available for tardive dyskinesia. Typical antipsychotics include chlorpromazine, thioridazine, fluphenazine, haloperidol, and pemozide. Are there any other side effects related to them? Yeah. Chlorpromazine, for example, is a strong autonomic side effects. Also, chlorpromazine has a C. It can lead to corneal deposits. Thioridazine has a T. It can lead to retinal deposits in the retina. Also, thioridazine is the strongest autonomic side effects possible. Oops, it can lead to torsade de pointe. I'm twisting around the point. How do I treat it? Magnesium sulfate. This can auto-treat the acute APS. So you have blocked your dopamine and you're having side effects. Now I will block the muscarinic receptors too much. I will kind of reverse or ameliorate the APS symptoms, which are extrapyramidal symptoms. Fluphenazine is available A and depot form intramuscularly. Who cares? Haloperidol is available intravenous, therefore, in case of emergency, acute mania, that's an emergency. Acute psychosis, that's when the patient is hitting you in the face, hitting the nurses, and screaming and like ripping off the IV lines, doing crazy stuff, you can give haloperidol. Mechanism of action is strong. Blocker of the D2 receptor can lead to severe extrapyramidal symptoms. It can lead to neuroleptic malignant syndrome and tardive dyskinesia. Don't forget to treat this with benzodiazepine and dantrolene. If it's so severe, you can add bromocriptine or amantadine. Pemozide, we can use it for tic disorder and Tourette syndrome. These are your typical antipsychotic drugs. We will talk about the atypicals in the next video. I love you.